Farm so hard, the employees wanna find me, and then wanna hire me. What's 100K to a guy like me? Could you please remind me? Farm so hard, this ain't easy. Working late nights, you best believe me. My grades can only go A's. Never wanna see another B unless I'm Jay-Z. Farm so hard, let's get paid.
This is Morgan Greer.
This is Micaela Hayes, and you're listening to another episode of the Farm So Hard Ambulatory Care Podcast.
Hi, everyone, and welcome to the Farm So Hard Ambulatory Care Podcast. I'm your solo host today, Micaela, and I'm so excited to introduce to you Dr. Jaron Stout. He is a doctor of pharmacy, and he also holds the Fellow of the American Society of Consultant Pharmacist Credentials, which is also known as FASCP. So Dr. Stout owns a collaborative pharmacy consulting company called Collaborative Pharmacy Consulting, and it's based in Salt Lake City, Utah. Welcome to the show, Dr. Stout.
Well, thank you very much for having me on the show. I'm honored to be here. And you say solo host, so I don't know if you're normally solo or if this is a unique situation, but I'm happy to be here and meet you.
Yes. So my co-host is Morgan Greer. She's awesome. She is not with me today. I'm sure she's busy working or having fun, hopefully having fun, but she'll be on with another podcast later, I'm sure. But First, I just wanted to kind of dive into how I came across you. So I was searching collaborative practice agreements after I finished residency. I was trying to learn more about billing for ambulatory care pharmacists, how to integrate into different clinics, maybe in the primary care space or in specialty pharmacy. And that's how I came across you when you were speaking with Perfecting Peds and Jenna Quinn. So could you tell me a little bit about how you got into your role that you're in right now with your consulting business and the path that led you here?
Absolutely. I'm happy to. So I've been a consultant pharmacist for 12 years. I graduated 2011. I kept my eyes open for a consulting gig because that's what I always wanted. And I got it nearly a year after I graduated, maybe about 8 months. And when I started, it was for a pharmacy. There was called Senior Care Pharmacy. And I started there, and they hired me part-time to start just to kind of see if I was a good fit for the job, because it is a job that historically you need somebody who's an engaging person because you're kind of the face of the pharmacy when you go to these facilities to provide consulting services. And so after the first 6 or 12 months, they realized it was worth it. So they kind of hired me full time. And yet, despite that, I would go to facilities and realize they weren't happy to see me, which was surprising. So they would be a little disappointed perhaps. And so I would talk to them and I'd say, well, I'm sorry, I thought we were friends. I thought you were looking forward to my visits. And they said, Jaron, we love you, but we know you're just gonna come here and give us a gigantic stack of paperwork to work through. And that honestly was the day my career changed. I realized that my services were not valuable. They were just busy work. And from that day on, I changed my approach and I started to think, well, is this a recommendation that's worth their time? Or is this just something I'm throwing into a formal report to show that I know stuff? You know, telling a nurse to monitor for bleeding because they're on 2 antiplatelet agents is really a waste of their time. They monitor for bleeding anyways. And so it started to make me think, oh, well, maybe I shouldn't be telling them to monitor. Maybe I should use my training and look at the meds and say, is this appropriate? Is this the right duration? Do we need to get rid of something? And then I started to take a much more clinical approach as opposed to just a box checking approach, which I think historically is unfortunately what we've done. And then one day I was just thinking how to make it so that I'm not just giving them extra paperwork. And I was listening to a podcast one day and they just said the phrase collaborative practice agreement. And this light bulb went off. And I just remember thinking, like, why is nobody doing this in nursing facilities? Why has nobody thought of this? And I think, we just get stuck in tradition and the way of doing things. And it's kind of like the car industry has been disrupted by Tesla or whatever, a new approach, a new concept, a way of thinking. And Now that I've been doing that, it's really taken off. After 5 years at Senior Care, they were bought by another very large pharmacy, and I knew very quickly that I was not a good fit there. And so about 6 years in, I decided to create my own company and focus on collaborative practice and collaborating with physician groups and finding billable opportunities and diversifying what consultant pharmacists do. And 7 years later, into creating my own company, I'm doing very well. I have about 50% of my local market, and rather than sitting on the 50%, I'm looking to expand what I do with that 50%, because my ultimate goal, I don't want to bog you down too much, but my ultimate goal is to make it, historically, one consultant pharmacist comes in and they go to 15 to 20 homes once a month, because that's the regulatory requirement, a monthly review. I want to make it so that we collaborate with physicians. We have more billable services we can provide through them. As you were talking earlier about Amina Abubakar, and she gave me tons of concepts and ideas that I've been able to make happen in nursing facilities. And so I want to make it so that one consultant pharmacist goes to 5 to 7 homes once a week and has a much more bigger role and a bigger impact that they can make. So that's kind of how I got where I am.
That's really cool. And I love how you talked about using, other pharmacists and what they're doing to inspire you to,
Right.
transition your approach, not just use a cookie cutter approach or just be an entrepreneur, right? As
Exactly.
pharmacists, I was talking to my dad today on the way home from work, and he was talking about how, you go to pharmacy school, you finish pharmacy school, and you don't just have to be like a pharmacist. You can create your own space just like you've done. And
Yes.
obviously, you're crushing it with 50% of the market share. That's awesome.
Yeah.
Congratulations.
Thank you very much. And the number of pharmacists branching out and doing this is growing every day significantly. I think we all recognize we've outgrown the current infrastructure, and it's time to stop being one-trick ponies, so.
That's awesome. I love that. Well, I have a question just from you talking about what you do, and I'd just love to learn more. So, are you able to work remotely doing this? Are pharmacists working remotely, or do they have to be, like you said, going into these different places?
Well, that's a good question. There's several layers to that. To answer your question rapidly, you absolutely can do it remotely, especially as we've gotten more electronic health records implemented. Historically, it's kind of a big no-no. And even though it's allowed now, and I will say that COVID obviously changed most of our industry, most of our social world. But as far as COVID goes, it made it normal to work from home. But when you're a consultant, like I said earlier, you're kind of the face of the pharmacy. And in my case, I don't work for a pharmacy anymore. So I'm the face of my service, my company. And any pharmacist I hire to go to these homes, they represent my company. And I need a face shown in that facility. I don't want it to be just a report sent remotely with no interaction with staff, no understanding of who the resident is or what their needs really are. Because there's a lot that you can learn in the facility talking to staff rather than just looking at a chart. And sometimes you can look at the chart, get the majority of the info you need, and then go to the facility, talk to the nursing staff. Hey, I was looking at this resident. Here's what I found. What are your thoughts? And you can get much better insight. So now there's a lot of flexibility as a consultant pharmacist. We have cushy schedules and a lot of flexibility in how we work and when we work. But at the end of the day, it's still a relationship-based business, and you want face-to-face interactions with your clients to show them that you're there, that you care, and that you're available when they need it. So I hope that answers your question.
Yes, definitely. I can't tell you how important just interacting with the team and creating rapport I've seen throughout my very small journey as a pharmacist so far in the grand scheme of things. It just makes a huge difference when you're able to build rapport with these people and then, solve their problems or
Yes.
help with a difficult patient, and then they trust you, and then it leads to more work, more collaborative work together to help, improve patient outcomes basically. The other question I had was, how do you go about getting these sites? Are you door knocking? Do you know these physicians or these people that you go and integrate with? How do you find them?
Good question. So I got lucky because I already worked in the industry within this region that I work in. I spent 6 years working in it, and I already had built up a strong network. And I already had a large number of people who appreciated what I was trying to do, even though I worked for a pharmacy that didn't really like what I wanted to do. And so when I branched out, I immediately had, I think the day I created the company, I signed 3 accounts on, which was ironically my birthday, the day I created it. It's like my 39th birthday, and I landed my first 3 accounts that day. And then, so I already had a network, and that helped. But I think the thing that really helped me spread and grow was physicians going to other facilities. So they would work with me in one building and go, wow, this is so much better than any consultant I've ever seen around here. So they would go to another home that I wasn't in and say, hey, here's a pharmacist you need to hire. Look at what he's doing here. Like that caught on like wildfire on a couple of different eras or periods of time. And so it's been a gradual, but when I grow, it's like this large clump at once. And then I kind of learn to stabilize. And then it's been a pretty steady growth over the last 7 years. And it's been exhilarating, but I think that answers your question. Like some of it, when I first started out, I did some cold contacting and just making it clear that, hey, I don't work for a pharmacy, so there's no conflict of interest. I'll actually help you get rid of meds. I work with your physician, and I give you items that are already pre-approved. You don't have to wait for them to come in the building and sign it. And I'm helping you get rid of sliding scale. I'm going to save your nursing staff time. I'm going to eliminate wasting time on warfare and monitoring and switch people to Eliquis, because in long-term care, they're covered by Medicaid generally. So there's not a lot of insurance concerns and whatnot. So I think that, so yes, there was cold contacting, but I also had a strong network.
That's awesome. That definitely answers my question. And then your examples that you went into, my follow-up was going to be, what was the major differentiator between you and what the companies that were doing alternatively to you that the providers were so excited about? But you gave great examples. So
yeah,
I could totally understand why they wanted you.
Yeah, and that's stuff we should have been doing for ages. And instead we had this archaic of approach of, hey, this medication has a black box warning, just FYI. And that's all we would do. It provided no, like literally a nursing home could go to drugs.com, type in a regimen and run a report. And that's what we were giving them. There was no assessment of the relevance or whether or not the risks or benefits were being reviewed. It was literally surface level. Here's a drug. It might be a problem. You should look into it. And we're better than that. We're doctorate level service, right?
Amen. I agree. I totally agree.
Yeah.
All right. I guess let's kind of segue into collaborative practice agreements. So first, I'll ask you to describe to the audience in your words and in your practice realm, what is a collaborative practice agreement or a CPA from your perspective in consulting and as an entrepreneur?
All right. So collaborative practice agreements, there's 2 different ways of looking at this. And I love collaborative practice agreements because it's the foundation of which I started. And over time, I feel like I'm starting to outgrow collaborative practice agreements, and we'll get into that. There's 2 things about them. One, first of all, let me give some context. Pharmacists have 2 huge problems. Do you know what they are off the top of your head?
Billing.
We can't bill for our time.
Yep. The second one, I don't know. I guess getting buy-in from the team, maybe. What's the second one?
So the second one is we can't prescribe.
Oh, yeah.
Right. So those are our two biggest obstacles of showing what we're capable of doing and having an impact and showing how we can improve the outcomes, right? So with a collaborative practice agreement, that is when a physician delegates their ability to prescribe to a pharmacist or to whoever they see fit, right? So it solves that one problem. The downside to that is it's just another way for us pharmacists to continue to give away our services for free. So yeah, it's great we can do that. And it was a valuable add-on for me to do that. But over time, I've realized it's still limited in what I'm trying to build because I can't spend too much time finding out how to write, doing risk and benefit analysis to find out which order to write when, right? So they're phenomenal in the fact that we can now build, I will say this, collaborative practice agreements are a phenomenal stepping stone to get to better objectives. And that is definitely what it has been for me. But the downside of collaborative practice is that it varies ridiculously from state to state. And some states, it seems like they've gone out of their way to make collaborative practice agreements irrelevant and unaccessible to pharmacists in general. It's strictly for institutional settings. It's strictly for academia. I know some pharmacists who aren't even willing to try because it's such a massive roadblock. And in all reality, if you have open lines of communication with a medical group that you're teaming up with, that serves and meets the purpose of a collaborative practice agreement. You can just text them anytime you have something you're going to do, and they approve it, and you're done. And in an information era, a digital era, it's so easy to have that open line of communication. And so if you live in a state where collaborative practice is just severely discouraged or difficult, just team up with physicians with open lines of communication, text availability, and just streamline the process. So I don't know if that answers your question.
No, that was perfect. That was wonderful. Okay, I guess you really outline the pros and cons of a CPA, unless you have anything different from that, or if you think that what you talked about just now covered it.
Yeah. So the downside, like I said, is that we can't bill for our time. And so one of the key things that I think pharmacists need to absolutely become familiar with, because this always comes up, because I don't know how much you know about what I'm working on. But I created a coalition. I have an attorney in DC, and we've been doing a lot of work building alliances, getting education out there for provider groups so that they can get familiar with how to team up with pharmacists, what services they can provide and get paid to do under Medicare rules. There's a lot of work to do there. And I think the thing that frequently comes up when we're out providing this education and getting more people aware is that people automatically jump to, I need a collaborative practice agreement. And in reality, you don't, because what you need is a business agreement with a medical group. Once you have that business agreement, you have a working relationship day to day with them. You're providing billable services, whether it be CCMs, BHIs, PCMs, annual wellness visits, incident 2 visits. It goes on and on and on and on. And if you have that working relationship with them, like I said, you technically don't need a collaborative practice agreement. And you're actually getting paid to do those services. You have an open line of communication, and that's what matters. And a lot of people think that a collaborative practice agreement is a business agreement, and that may vary by state. There may be a state or two that require them to be together. I think there might be one state that requires that. But generally speaking, if you have a business agreement, open lines of communication, that will be all you need. And theoretically, the minute you have a collaborative practice agreement, you are now allowing your actions to be regulated by a board of pharmacy that may not fully understand or have any room delegating or regulating what you're doing in a medical group per se. So I don't know if that makes sense, but I think it's a frequent misconception. There's a distinct difference between a business agreement and a collaborative practice agreement.
I have a couple questions about business agreements because I'm not as familiar with them. I know about collaborative practice agreements, but kind of walk us through what the major differences in a business agreement are and how you get a business agreement.
Yeah. So a business agreement is where you spell out, here are the services that I can provide for you. Here are the CPT codes that I can perform on your behalf under your medical group and your NPI. There are several ways to set it up. Some people I've heard say you can't do a percentage-based setup. I've yet to see how that's a legitimate problem regulationally wise, but there are ways you can set it up. If you set it up as a percentage base, the downside is now you have a problem where you have to wait for the physician to get reimbursed before they'll pay you. And sometimes they will fail to get that reimbursement. So it requires a lot of due diligence to kind of review what they have incoming for your services, to kind of audit that and monitor that to see if they're getting paid for your services so that you can get paid. So there's a lot of work that goes into that. If it is percentage based, depending on the rate you get, it can be a high payoff, but a lot more work goes into making sure you're getting it. Other ways of doing it, a flat rate. So you know that a medical group gets paid, let's say $65. So if they're doing a CCM, let's say they get paid $45 for a 20-minute billing code. That's roughly about where it lands. You can create a flat rate and say, okay, if I wanted to get 75% of that, that would be roughly $31, $32. So how about I do a flat rate? You pay me $32 for every CCM that I perform for every 20-minute interval. You can go up to 60 minutes. So that's another thing you can do. It works for you because you don't have to wait for the reimbursement, but the medical group is less likely to do that because they would rather,
get the money first.
All parties are benefiting at the same time, and they don't have to. Now, depending on the size of the medical group, large groups are less likely to team up because they can kind of build this in their own way. But smaller groups also don't have quite the capital, so they're less likely to do that. That being said, there is a formal recognized payment process created by, I think CMS created it, but it's called RVUs. Have you ever heard of RVUs?
I have, but I'm not super familiar with it.
Right. Now, unfortunately, I forgot what it stands for, so I couldn't tell you that off the top of my head. Something revenue, something units, I think is what it stands for. But basically, one RVU represents roughly 15 minutes of time. And every billing code has a set, like for instance, if you perform billing code 99309, which is an incident to visit in nursing facilities, that represents, I think, 2.56 RVUs. Oh. And you would get paid. So if you get paid $20 per RVU, you'd get paid $40-something for that visit, right? Now, that's a set rate. And the good news with that is you get paid that no matter if they get reimbursed or not. So it's up to the medical group to ensure that they get paid for those services that they paid you to do. The downside is it's not as big of a payoff. It's a smaller number, but it really benefits both sides as far as it probably benefits the medical group more, but it also makes them have to put in more diligence to get paid for those services. So as far as a contract goes, there's 3 different ways you can set it up: percentage-based, flat rate, or an RVU rate. And depending on the medical group you talk to, they'll want different things. So a business agreement is where you set out, here's the services I can do, and here's how much you're going to pay me to do it. A collaborative practice agreement is just a set of protocols. When I find metformin and their GFR is below 45, I'm going to renally dose it or discontinue it if appropriate. So it's protocols of where you are utilizing your clinical expertise to dose medications or use medications appropriately.
Definitely. Yeah, I feel like I've dabbled in starting services and practices, and I created a business agreement without really, you have to create a business agreement with the person to get paid or the
Right.
practice to get paid, because if you think about it, you just go in and do a CPA. Maybe if the practice wants to hire you and take you on as their pharmacist and pay you a salary, that works to just do a CPA. But otherwise, you're a business and they're a business, and you have to show how you are going to help them be more profitable and help improve their patient outcomes and reduce hospital admissions. But then at the end of the day, they're like, okay, well, how can we get you at the best price?
Exactly.
And then that comes down to billing. So definitely makes sense what you're saying. I think that the business agreement makes sense. And I didn't even realize that that was an option where you could just get the business agreement and then cut out the
Right.
CPA part. I
Yeah,
mean,
and most
what's
people
the
don't need it.
liability look like for that with a pharmacist license?
That's a very good question. I will say that I use Pharmacist Mutual. I'll give them a plug since we're on here. But the thing that I liked about them is I reached out to them because I was like, man, I wonder what this is going to do to my insurance. I reached out to them. We had lunch. I explained everything I was working on and how far above and beyond I was going, and they didn't change my rates.
That's awesome.
So, I mean, I think the way they view it is, yeah, it's liability, but it's just a different liability because I'm not in a pharmacy. So I'm trading in that liability for a new one.
Right.
And that's the way I've got it figured out in my head because it really didn't impact my rates at all.
That's awesome.
So I think they recognize that it's just a different liability and I'm trading in one for a new one.
So with that plug, what, I guess, pharmacist liability insurance would you recommend to new pharmacists on the block?
Pharmacist Mutual is great, but I will also give a plug to ASCP. I think they offer it. Actually, I think they team up with Pharmacist Mutual. I'll have to look a little deeper.
No worries. No worries.
But I know there's another one out there that I haven't looked at yet, just because I felt like I was being treated very well with Pharmacist Mutual. So
yeah, ASHP sends me letters all the time about liability insurance, so that's the one that comes to mind with me. But I love your perspective.
And that's the thing is I think I've gotten some from ASCP as well, but I don't know if it was through them or if they were promoting a different one. I get it in the mail, but I don't dive through it very much.
Right. That's just like the extra mail where you're just like, oh, toss.
Yep, exactly.
Unless you need it, and then it's super crucial.
Right.
So you talked about how you created a coalition and you're advocating for advancing the profession in this consulting realm. What advocacy, go into the advocacy efforts that you're doing, and what can we be doing as pharmacists interested in non-traditional roles to advocate to advance our profession?
Yeah, so I think one thing I wanted to touch on that you mentioned earlier, I forgot to touch on. I think what I'm working on has a lot of crossover capacity with ambulatory care. And so I think I would love to do more discussions with people that are in ambulatory care, because I think what I'm doing is similar to that, but it's in a much higher, more complex population, and so there's a lot of stuff that I'm working on and doing that I think ambulatory cares would love to do and would thrive at. And so the downside with current ambulatory care, and I may be wrong about this, but I always get the impression that they're hired by a medical group or whatever, and they do these services. But I don't think medical groups know how much they could be making off of pharmacists with all these billable services. They have no idea they can bill for. And I think if they knew that, we would have more pharmacists working in ambulatory care, because like I said, our two biggest problems, we can't prescribe and we can't bill for our time. Once we get physicians familiar with how to utilize a pharmacist and how to bill for their time within their group, that has enormous potential for us to start expanding outside of the pharmacy. So that's one aspect of it. I would love to get more communications with wonderful ambulatory care pharmacists like yourself. And I would love to start getting the word out so that pharmacists know that these opportunities are available. That being said, the numbers of pharmacists doing this type of stuff is growing every day. And more of us are starting to think outside of the box. More of us are thinking about how to have a more fulfilling career, utilizing our training rather, because I'm not being crazy when I say most of us don't utilize the full capacity of our training in most settings where we work. And so the advocacy is to initially it was to get more clarification, because there's a lot of misconception about Incident 2 and how the regulations apply to pharmacists, first of all, and second of all, to nursing facilities. Because when I first started to research it, I was told, nope, nursing facilities are an institutional setting, and so you can't do Incident 2 there. But the deeper I dug, the more I found out that was more complex than that. And then I reached out to my MAC provider. Do you know what a MAC provider is?
Yes,
Okay.
I've heard of it, but tell our audience, please.
Yeah. MAC provider is a Medicare administrative contractor. And when I first started looking into Incident 2, because of the Blair Telemeyers of the world and the Amina Bubakars of the world, that's what got me thinking, oh, well, what is Incident 2? I reached out to my MAC provider. They thought I was crazy, and they said, nope, can't do it. And I said, well, I know why you're saying that, but I'm looking directly at a letter from CMS stating that pharmacists can do it. So I need to speak to your superior. And they kept pushing me higher and higher and higher. And then finally, this guy said, I don't know what you're talking about. Here's the number to a person at CMS office in Denver. So I emailed this person. We had a very brief correspondence. She was super friendly. I said, here's what I'm trying to do. Here's the references that show that I can do it. Here's my interpretation. And she responded that I had interpreted it correctly, that it could happen in nursing facilities. So this is just one instance, and most pharmacists would just give up as soon as they heard no. I'm very fortunate that I really pushed it because I felt like there was something there that was not giving me the answer. It was conflicting. And so the coalition was created to find more information, to get more information out there, to make more pharmacists aware of how they can branch out and perform billable services with medical groups. There's a ton of confusion around it. And even with an attorney helping me, we often felt like we were taking one step forward and 3 steps backwards. It was super frustrating digging through those regulations and finding all the problems there. And I could spend several episodes digging through the weeds with you, but I would probably put your audience to sleep. So the coalition was created to get the word out, to have more education. And our ultimate goal is eventually to be in CMS headquarters, to show them, here's what we know to be true based on what you told us. Here's all of the conflicting data and interpretations from your MAC providers that are all interpreting it incorrectly. We need a formal clarification that this can be done, and etc. So that was the ultimate goal to start with. And it's morphed into a few things. Right now, we're also creating an alliance of innovative pharmacists, and we wanted to keep it small at first, but it seems to be growing quite rapidly. But we had a meeting in DC a few weeks ago. There was about 10 to 12 of us, and it was hosted by the American Society of Consultant Pharmacists, because I've been trying to convince them, me and Lee Davidian, my attorney, have been trying to convince them, convince Chad Wers, the CEO, that there's a ton of pharmacists who don't have any support, any infrastructure, any help. They're all branching out and doing things, but they don't have any organizational support. And so I'm trying to convince them to start taking on this task of providing a home for all these innovative pharmacists trying to branch out of the pharmacy. And that's an aspect of it that has recently morphed, and it's growing. So yeah.
Definitely, it definitely did. I love pharmacists who go outside the mold and create something completely new, like the Blair telomeres, like you said, or yourself. I mean, you have to really be persistent and ask and be told no, and then go to the next and go to the next and do your own digging. Getting an attorney, I mean, I can't even imagine the uphill climb that you made to get to where you are.
Unending uphill, yes.
Yeah, and we're so thankful because you're a trailblazer in this space where then pharmacists with a passion for working in a non-traditional role or starting a consulting company in a different area that really needs it, it's so valuable. And seeing someone like you going and doing it just inspires. And this is why I wanted to even start hosting podcasts, was to be able to meet people like yourself and get inspired and learn how you built the company, almost like the Guy Raz of how you built this, but pharmacy edition, right?
Yeah, absolutely.
So that is super interesting and I love it. And if you ever need information out there to get people on your team to help with advocacy, I'll be the first one to shout and I'll be the first one to help you. So just let me know.
Awesome. Yeah.
Sorry.
And just one last thing on that. I've expanded into 4 states, small levels, but I'm currently finalizing a deal with a behavioral health provider they're in 8 states, and there's a lot of potential there. There's a lot of need of pharmacists managing psychotropic meds in nursing facilities, because there's tons of regulations around that on how they can use psych meds in nursing homes. And so there's a ton of untapped potential for pharmacists, and there's a huge need for us because of the growing gap of providers that are able to provide these services. Plus, we're going to have aging population, and we're going to run out of long-term beds in about 5 years. So we need pharmacists to bridge this overwhelmingly large gap of need for clinical services.
Yeah, and I took one elective in geriatrics during my PGY2 at Duke, and so we worked in a geriatric specialty clinic, basically, at Duke University Hospital. And then we also, in my rotation, would work with different long-term care facilities that were like the patient had to go to a SNF, and it was a patient within this geriatric specialty clinic. There was so many discrepancies that were found just because of the amount of medications that geriatric patients are on. Number one is overwhelming for any provider.
Yes.
And then you get a whole group of patients on an overwhelming amount of medications. There's bound to be discrepancies and things that are missed. And we really, as pharmacists, really help this population, being medication experts, looking for drug interactions, looking for ways to optimize therapy or reduce therapy. I mean,
Right.
we, as a mid-level practice, helping physicians can really make a big difference. I think that they don't even understand how much we can help them improve their first of all, their overall well-being, the providers, right? They're burnt out.
Right.
They have too much on their plate. They're trying to hire, mid-levels, but they don't understand they have someone who can really help with the medication aspect, and that's a big factor.
It is. It's a huge factor. And I've often wondered why there's not a huge interest in geriatrics for pharmacists, because in my opinion, it's like a pharmacist playground. Like we have all these comorbidities, all these disease states that we like to manage, and polypharmacy is present, so we can assess the relevance and need for 20 meds at once. And it's everything we love to do, especially, like I said, with ambulatory care. Like, I think there's a lot of potential here for crossover and collaboration in that. So it's a fun area to work. It really is.
Definitely. And what I like about ambulatory care, and I work in a transplant position right now, inpatient and outpatient, kind of what I told you earlier. But what I love about transplant is you're managing chronic disease states. I mean, it is tried and true AM care plus the transplant because they have diabetes, hypertension, all the things. And that's my bread and butter. And then I learn, the transplant aspect, and that's just another piece of their chronic disease state that we're managing. But geriatric is the same way. It's very diverse because you're seeing patients with a multitude of chronic disease states that you can manage, just like you said, a pharmacist's playground, right?
Yeah, exactly.
That's awesome. I love it. All right, I am going to go into another section or a different, pivot here. So what do you think are the major hurdles that you've encountered throughout your journey in entrepreneurship, and what advice would you have to someone that's looking to either start consulting or maybe join a consulting pharmacist firm?
I will say that for me, I had no formal business training. And I think I anticipated that I would just take over, a few homes in the local market and just be content and happy. I would have been content and happy with that. But as it's continued to grow, I had no anticipation that it would grow to where it is. I had no expectation of that, so I didn't plan for it. And I think I'm suffering for that now. Like learning how to hire people, how to have a payroll, how to have an HR. That's been the biggest hurdle for me. Learning all this new business management aspect that I never thought I would need. So I will say, go into it with the frame of mind and plan. And maybe part of it is because I have ADD, but like, even if I had plans to grow, I don't know that I would have planned very well. I just wait until I need to do it and then I do it. But I would recommend taking a more proactive role and look into what you need as a business grows to make it so that you're not overburdening and burning yourself out. Because even though I love what I do, I can see how I could get burned out if I don't team up with the right business partners and get the right infrastructure set up. So that's been, for me, the hardest part to learn. And I'm sure many pharmacists can relate to that.
Yeah, I can understand how starting a business. My father is an entrepreneur. He has a construction business, nowhere near the pharmacy realm, but my entire life he's had this construction business. And when you start a company from the ground, you are everything. You are HR, you are,
Everything.
doing the minute details all the way to the big picture. And it's hard to, when you get a system going and it's going well, the next step is to grow. You have to delegate, and that's hard, or even knowing when to delegate or preparing, like you said, to grow. You don't know until you get there. And I've been listening to entrepreneur podcasts. There was one called Millionaire University. I can't remember the name. It's a husband and wife couple, but they were talking about how entrepreneurship is where you just go into a dark room with the lights off, and then you step into the unknown, and then the lights come on and you see the next step. You don't necessarily know all the steps. You just know this is the next step right now. Okay, we'll go, and then pivot as we get there.
Yeah, that's a very good analogy. Yeah, absolutely.
Yeah, so I definitely see my dad doing that even to this day. But there's a spirit within entrepreneurs, like even your signs in the back say, like, you don't stop, you never give up. There's a million things on the to-do list, but just you wait.
Yeah. So
exactly.
That's actually a Beastie Boys quote and a Hamilton quote. So
I love it. That's so awesome. And totally you, based on your story.
It is very much me. Yes, you're very observant.
Okay, kind of finishing up here, looking ahead, where do you envision the future of pharmacy for maybe provider status? Take this question where you want to. Where do you envision your future with consulting or the future of pharmacy consulting? Where do you envision the future?
I think the current trend is going to continue. I think we're getting fewer applicants for pharmacy school because it doesn't appear to be very rewarding. We're getting fewer people who want to stick around in pharmacies because it's not fulfilling what their training has given them and prepared them for. And that being said, I don't mean that to be a detriment to working in a dispensing setting and being in a dispensing pharmacy. I think there are a lot of things that we pharmacists can do that we just haven't been doing, because I feel like we've just been stuck in an archaic process. We are really good at coloring within the lines historically. And I think we are now starting to learn as a whole, we can color outside of the lines. And I think that trend is growing, and I think it's going to continue. And I think, to me, that's a beautiful thing, because I think we were limiting ourselves by sticking to one setting and kind of being relegated there. And that being said, the billable opportunities that we have at our disposal, to me, what that means is provider status, schmovider status. Who needs that? We don't need it. We have plenty of opportunity before us with the current healthcare infrastructure to go out and start using these opportunities to not just beg and plead for provider status, but go out and prove that we should eventually become providers. So I think we should put our money where our mouth is and prove it. I think that is going to be a growing aspect, especially if what I'm working on with Lee continues to grow as it has. So in my opinion, to answer your question, I think we're outgrowing our old way of doing it. But that being said, the old way of doing it is still a beautiful thing. And I would love to see pharmacists still provide in that setting. But we're also smart enough, brave enough, and amazing enough to work outside of that setting as well. We're not one-trick ponies anymore. We're clinicians, and it's time to go out there and prove it.
Wow, that's beautifully said. I'm so inspired. I love it. Yeah,
Thank you.
pharmacists, we like black and white. We don't like the gray
Yeah.
area, right?
We don't.
And even when states get provider status, the pharmacists, I hear from other pharmacists working in ambulatory care mainly, they don't know what to do with it. And they're worried about, like you said, coloring outside the lines. Even when it's granted to us, it almost creates more problems because they're like, okay, well, what do we do? What's the liability? What risk are we at? You know, we're so black and white that if it's even gray, we're just like, well, we'll stay on this side of the line just for
Yep.
good measure, right?
Yeah.
Totally
And that's
see
just
that.
limited us for a long time, and it's stopped us from meeting our full potential, in my opinion. And you know, it's funny, even when we have opportunities, we haven't been doing anything about it. I know in Ohio, pharmacists have provider status. They can bill Medicaid, but nobody's doing it. I mean, not very many. And part of the problem is even the ones who are doing it, and a good friend of mine, Courtney Myers, is doing this, and she's part of what the group I've been building of innovators. She's a good one for you to have on the show as well. So
Oh, okay.
she's run into problems where she can't bill Medicaid unless she has a failed claim to Medicare, and she can't bill Medicare because she's not a Medicare provider. So she has to submit a fraudulent claim potentially just to get the claim paid through Medicaid, which
Wow.
is totally inappropriate. But right now with the infrastructure, this is the kind of stuff we're running into. And if we want to grow as a profession, we need to all meet together and communicate these barriers that we're running into so that we know how to address it, how to attack it, and have a professional organization that'll have our back in those situations.
Yeah, that's awesome. Yeah, we need like one body, like you said,
Yes.
to really advocate for ourselves. And even I was listening to a podcast that I think it was from ASHP, and they were talking about how we can advocate for progressing our profession. They're like, we need pharmacists in the community on like community boards, on like the school board or
Yeah.
different places to really show, okay, I'm a pharmacist and this is what I do, and let the community know, what the value of a pharmacist, and maybe it will trickle into where we need it to be. But
Yeah.
just like you said, we need a governing body that is one voice advocating for the advancement. I totally
Exactly.
agree.
Yeah.
And you're the man to get it started, right?
I hope so. I feel like I've met a lot of amazing people started with this process, and I feel like it's growing and it's coming along. So it's long overdue, and we need to unify our voices because we haven't historically done that.
Definitely. One thing that I thought of when you were speaking on how we can advocate for ourselves and how we can grow, where the future is going. Do you have any concerns about the billing and reimbursement changing or regressing, becoming less available to pharmacists, or, what do you think about that?
Very good question. And the only reason that there is a potential for that is because technically the billing codes are more accessible because of COVID. COVID
Mm,
lightened up a lot of the restrictions and made it easier to do. Just as an example, this is the only real problem is when doing incident 2 in nursing facilities, I had to coordinate with the physician to be in the building at the same time. And that doesn't make any sense, because if a physician hires a nurse practitioner, they always stagger and don't show up on the same day because they can't see the same patient on the same day. They don't want to overlap. But I had to be there on the same day and then do a lot of coordination to make sure I didn't see the same patient. And if I couldn't see somebody that I wanted to see, I had to wait another week when we'd both be in the building at the same time. So COVID changed the incident 2 rules from direct supervision to general supervision.
mm,
And that flexibility is scheduled to expire at the end of this year.
mm,
But there's already a lot of professional organizations, not even pharmacy related, that want to make this permanent. And CMS has a lot of interest in making it permanent. So there is potential, but currently CMS wants to gather more data, and it's highly likely that they will extend this as a permanent thing. Or if it's not fully where it is now, it'll be similar to where it is now, like maybe it'll still be available, but only in specific settings as general supervision, like in nursing facilities. To me, that would make the most sense. Or they could also extend and make it so that telehealth will bridge that gap. Instead of
mm.
having to be in the building at the same time, you could use telehealth instead.
Okay, that's
So
awesome.
so to answer your question, yes, there is a possibility, but there's still plenty of other options and technologies that will bridge those gaps from becoming a problem.
Awesome. And then with auditing, like if the billing that the pharmacist is doing gets audited, if they are, I don't know, when they audit or when CMS sees that we're doing a lot or billing a lot, and is there a potential where they're like, oh, we really don't think that they should be billing this much for this service, and they might take it back or step back. Do you think that could happen, or do you think that they're okay with it and they want us to see as
Well,
many as we can?
good question. So keep in mind, when the bill is submitted, we pharmacists aren't submitting it. So I guess that's something to be aware of. When we do these services, we're not providers, so we can't do it. The medical group is the one who hired us and said, we want you to perform these tasks under our wing under our NPI number. And they'll have one supervising physician. It'll go under that supervising physician's NPI. So on the other end, they don't even see that it's a pharmacist. It looks like it's coming from the physician, and that's totally legit and that's totally appropriate. The intent of the incident 2 regulation was to stretch the services of physicians and have them identify who they're comfortable delegating these services to. And so there's never going to be any kickback saying, oh, we're paying these pharmacists or reimbursing these pharmacists too much, unless it's from the medical group. They might want to say, oh, look, we're actually losing money. So from that perspective, that's the only thing you would have to worry about, is occasionally recognizing that maybe the rate we negotiated isn't fitting everyone's needs and we'll have to renegotiate. Does that answer your question?
Yes, definitely. These
Okay.
are, yeah, these are all things that I've heard and I wasn't sure about, so I wanted to get your perspective on it, and that definitely answered my question.
Yeah. And, you know, just FYI, the attorney I work with, she meets different medical groups every like month who reach out to her and say, "You're telling me that we can hire a pharmacist? How do we do this?" So the desire is out there, the market is out there, and it's untapped, and we just need to get more pharmacists doing it.
Yes, that's awesome. Yeah, I remember hearing you on the YouTube video that I think I saw. It was a podcast maybe with Perfecting Peds.
Yeah.
You were saying the same thing, and that was a year or two ago, maybe even longer. And they were where the attorney was getting questions from provider groups, and they're like, "We want this." And pharmacists are out here wanting to be more clinical or wanting to transition into a different, I guess, realm of pharmacy, non-traditional, or maybe they want more clinical work, or maybe they want, something totally different than what they're doing. And then here we have, like, we know that there are people that need us, and we know the value that we bring to a clinic and to patients. So it's just, getting the word out and showing pharmacists the way. And that's exactly what you're doing.
Yeah, exactly. And I hope it's working.
Yeah.
You found me, so apparently I'm out there, and people are starting to catch wind of it. So it hopefully it continues to grow.
Yes, definitely. Well, as we wrap up, what advice or tips do you have for both new and seasoned pharmacists when it comes to navigating the realm of non-traditional pharmacy positions and pharmacy entrepreneurship?
Comfort brings complacency. So get the hell out of your comfort zone and start exercising and operating at the top of your license.
That is phenomenal.
I'm just going to keep it as concise as I can, but I hope that is good.
It definitely answered my question, and this has been an absolutely wonderful hour I've spent with you. Thank you so much for your insight and talking about your business and talking about, billing and all these things that I think are going to be, one, so helpful for me as a pharmacist. I know our audience is going to glean great information from today's conversation. And if there's anything else, is there anything you're promoting, anything that you want to get out there, ways that people can connect with you? Tell us where we can reach you and what you're doing.
Yeah. So, as you noticed, reaching out to me on LinkedIn is effective, but very delayed. So, so please reach out to me, and please be patient. I'm just trying to deal with a lot of growth and a lot of training new staff, and everything's just hitting me all at once, and it's been a little crazy. But so I think I would like to say that with the growth opportunities I have on the table at my disposal already set contractually that I don't have the manpower to take on, I have enough to take on probably 3 more pharmacists right now. And that's not including the stuff I have that I'm going to be signing in the near future. So, but my problem is capital. I don't have the capital to just go hire 3 pharmacists at once. Like I said, I didn't expect to be a business owner. I'm looking into business loans. I don't know how to do all this stuff. So, I want dedicated pharmacists. I want people who are interested in maybe having a team up of somehow, who want to join our efforts somehow. So that's where I would like to emphasize that I need more pharmacists, first of all, if you're interested. I am growing, so it's not just Utah. And in fact, I would love to get out of Utah if I grow out of Utah. So, so that's what I would like to emphasize is if you are as dedicated and interested in this as I am, please reach out and be patient. I will eventually get back to you, as you noticed.
If someone's interested in, being one of those pharmacists to help you, are you looking for someone from a specific location? Can they be remote? Do they need to be in Utah or the surrounding area?
As I grow, I will need people just kind of bridge some gaps. And so a lot of that work can be done remotely as I'm trying to figure out how to implement and where to implement face-to-face type of services. But I think Western US is where my biggest footprint is. But that could easily change with some of the discussions I've had. So there's no limit there. Let's keep this wide open.
Awesome. Well, thank you so much for coming on today's show. It was an absolute pleasure. And you're welcome back anytime. If you have something going on, you want to talk about it, we're here to listen and help you in any way that we can. So thank you so much.
Yeah, I'm honored with the invite. Thank you for thinking of me and finding me, and I'd be happy to return anytime. So.
Awesome. Well, thank you to our audience for tuning in. Don't forget to like, comment, and subscribe so you never miss another episode. And if you're enjoying things like this and you want more information or if you have questions, feel free to comment or reach out. And yeah, we'll catch you next time on the Farm So Hard Ambulatory Care podcast.
So I farm so hard, employees wanna find me, and then wanna hire me. What's 100K to a guy like me? Could you please remind me? Farm so hard, this ain't easy. Working late nights, you best believe me. My grades can only go ace. Never wanna see another B unless I'm Jay-Z. Farm so hard, let's get paid.
This is Morgan Greer.
This is Micaela Hayes, and you're listening to another episode of the Farm So Hard Ambulatory Care podcast.